Welcome everybody. We'll give one more minute to allow people to join and then we will get started. All right, everybody, let's go ahead and get this party started. Thanks for joining me this morning, or afternoon, rather, wherever you're from. Thanks for tuning in. This session is called Boosting the Brain, Dual Tasking Principles and Applications. I really appreciate everybody taking the time today, and I also appreciate what this virtual summit represents, the integration of rehabilitation and fitness for the aging community. So thank you so much for being here. This is a really important topic, and it's often a topic that is not talked about in both the rehab and fitness communities for a variety of reasons. Neuroscience is not something that is required as a majority of our education unless you're a neurological physical therapist. In some cases, speech language pathology and occupational therapy will include neuroscience education, but specifically for fitness, which is the background that I come from, neuroscience education is not something that is often normalized, although we're all pretty interested in how the brain works and how we can impact brain health through the interventions that we're providing. So I'm really excited to talk to everybody today about this topic, and thank you so much for joining me this afternoon. So let me just introduce myself. My name is Ryan Glatt. I've been a personal trainer for about 10 years. I work at a place called the Pacific Brain Health Center, which is an integrative multidisciplinary clinic that includes neuropsychologists, psychiatrists, and neurologists, as well as all sorts of amazing support staff and clinical researchers. We do research on a multitude of different topics, as well as we see people with cognitive concerns, individuals with Parkinson's disease, multiple sclerosis, mild cognitive impairment, dementia, and those looking to slow that curve of cognitive aging. My bachelor's is in exercise science, and I'm in progress with my master's of applied neuroscience from King's College of London. I'm just about a couple months away from finishing that, writing my dissertation on the effects of exercise on neuroinflammation or inflammation levels in the brain. I'm a brain health coach and a functional aging specialist, among other things, and neuroscience is my passion. I've been fascinated by the brain even before I got into the fitness industry. Some of my personal story includes having a traumatic brain injury, rehabbing from that, struggling with lifelong ADHD, as well as just knowing that my mental faculties are how I deliver value to the world. And so it's important to protect those, to improve those. And also it's fascinating to know that, we can improve all sorts of things through fitness, functional outcomes, weight loss, muscle gain, balance. But I think we're all interested in making a deeper impact in our clients, ourselves, and our communities. And therefore it's really important for us to know what sort of effects can we have on brain health and cognitive functioning. And so with that understanding and desire for greater impact, that's why I've been so fascinated by neuroscience, and not just neuroscience theoretically, but neuroscience practically. And so understandably, you're all here, and therefore you have some sort of interest in neuroscience as well. And if you have any questions about any of the topics we're discussing throughout today, please go ahead and use that chat or Q&A function, and I will be very attentive to your questions and concerns throughout this presentation. So I'm honored to be here with you, and thank you for trusting me today to deliver some neuroscience information. But why do we care? What's the problem currently that the world is facing? Well, quite clearly, it is this cognitive decline epidemic. And you'll hear a lot about Alzheimer's disease, which is the most common form of dementia. But it's not just about Alzheimer's disease, it's about cognitive decline in general, and these neurodegenerative diseases being primarily the focus, but there's a stage that people go through to get there. And we want to slow that cognitive trajectory as much as possible. We'll talk about that. But clearly by 2050, with 106 million people estimated to have Alzheimer's disease, by the year 2050. That's a lot. And you can see over time, this is increasing. And I'm not an expert in epidemiology, but some of it has to do with baby boomers and the population ratios, as well as people living longer and the world having more people. Now, there's some statistics showing that we're actually better at slowing the rates of neurodegeneration because of advances in medicine and improvements in lifestyle behaviors. But this is still a huge concern. This cognitive decline epidemic is something that we really need interventions and strategies for slowing this down or preventing it altogether. And so this is not just in the United States, this is all across the world. I think one of the biggest continents struggling with this is Asia, primarily due to population size, among other things. And so you see this increasing exponentially across the world. It's a global, worldwide trend of cognitive decline, and we want to slow this as much as possible. But how does cognitive decline actually work? When we talk about cognitive decline, what are we talking about? When we talk about aging, we think about these aging curves, and cognitive decline is no different. And so I'm going to break out my annotation tools here just to show you. What we're interested in is slowing that trajectory in this cognitive aging process as much as possible. So we want to look towards that top green line. That's the ideal. We want to be on this top green line. Now, if we look at that middle green line, we would all agree this is a faster cognitive trajectory, but it's certainly a better one than the blue line, the one below it. And this is a faster cognitive trajectory. So overall, what we're looking at doing is slowing the cognitive trajectory. Now, there's 3 different phases of cognitive decline for the purposes of this presentation. The first phase is what we call the preclinical phase. And what that means is individuals may not have a diagnosis of any cognitive impairment. But this can include people with what I would call normal, healthy cognitive aging, but it would also include people with what's called subjective cognitive decline, which essentially means you have noticed that your cognition has declined over time. It's also possible that maybe someone else has noticed that you're not paying attention as well, you're not concentrating as well, you frequently forget where you put your keys, for instance, but there's nothing diagnosable quite yet. I would argue that most of the clients and or patients that you are working with are primarily going to be in this preclinical stage. Unless you happen to work with a lot of individuals with mild cognitive impairment or dementia, it's likely that we are assuming a majority of the people may have some cognitive struggles, but most of them are going to be in normal cognitive aging. Some of them with maybe subjective cognitive decline. But what is also very possible is that you're dealing with people with early or undiagnosed mild cognitive impairment. And mild cognitive impairment, or MCI, is cognitive changes that are significant enough to be of concern to an individual or a family member, and they are detectable on tests and therefore diagnosable. This is a diagnosable condition. SCD, or subjective cognitive decline, is also something that can be diagnosed, but won't show up significantly on testing. However, MCI, this is more significant on neuropsychological testing. And so one or more cognitive domains may be significantly impaired. For example, memory. Memory is significantly impaired, and this individual is amnestic or has trouble with remembering names, faces, events, things of that regard. However, activities of daily living are still well preserved. Then we have dementia, and there's a lot of different types of dementia, Alzheimer's disease being one of the most common types of dementia, but there's also vascular dementia, Lewy body dementia, frontotemporal dementia, Parkinson's dementia. And there's different stages of dementia that can go from mild all the way to severe. So what we're interested in doing is intervening with these individuals to slow this cognitive trajectory as early as possible. Ideally here, so maybe we have a hope of going from what an individual might be on this blue line to maybe that green line, or even this green line right here. If an individual does have MCI and they are diagnosed, then we have an opportunity to aggressively intervene, we hope, and maybe go to this blue line or this green line, or maybe just stay on this light blue line and not go to this dark blue line. And also we have an opportunity to maybe go like this or just slow this curve. So you get the idea that we want to intervene as aggressively and as soon as possible to slow this cognitive decline trajectory for ourselves, our clients, our patients, those that we work with. Now, cognitive decline isn't just reserved for mild cognitive impairment or dementia. Cognitive issues also occur in a variety of different modalities and comorbidities. comorbidities such as congestive heart failure, syncope, changes in blood pressure within falls, COPD, diabetes, individuals with sleep apnea. So it's even more likely that even if they don't have a diagnosable condition like mild cognitive impairment, people can experience cognitive difficulties because of a variety of other comorbidities or behaviors. So it's important to know that there's a likelihood that this individual with hyperlipidemia, or this individual with high blood pressure, or this individual with a history of cancer, all of these individuals are at risk or may have cognitive impairments. And there's other conditions that affect cognition and brain health, medications. If we look at the geriatric community and how over-medicated they can be, or just recognizing that it is more common for older adults to have medications. And medications can affect cognition, both in good ways and in bad ways. Obesity and metabolic disorders. So we talk about the obesity epidemic. Does that relate to cognitive decline? Well, more research is showing that it does. It has its impact on brain health. Cardiovascular conditions, this is a really important one. So even high blood pressure, if we can treat that high blood pressure with exercise therapy or home exercise program or a fitness regimen, that is going to be impactful for brain health. And then cancer and chemotherapy is also another big one. We know that exercise can help with cancer-related cognitive impairments and help to rehab or slow the cognitive decline that can be a result of chemotherapy, for instance. Now, can the fitness industry actually make a difference? Well, there's 5.8 million people living with dementia. That's a 2018 statistic. There's 400,000 personal trainers in the US, and that's about a 12-to-1 ratio. That is not including rehab professionals, physical therapists, occupational therapists, and speech language pathologists, as well as relevant aides and assistants. If we put those numbers together, it's even greater. It's a greater opportunity to make a dent on this cognitive decline epidemic. So if our exercise programs are keenly aware of or integrate aspects of brain health, this is important to consider. So in order to consider this, we have to understand some basics of neuroscience. How does it work? How can we actually start to change our clients and patients' brains for the better? Well, there's a concept called cognitive reserve, and we talked about slowing that cognitive trajectory over time. And in order to do that, we need to contribute to what's called cognitive reserve. It's basically like your brain's gas tank across the lifespan for you to be able to slow or prevent neuropathology or neurodegeneration. So individuals with a low cognitive reserve will likely run into neuropathology or neurodegeneration events faster than those with a high cognitive reserve. And there's several things that impact this cognitive reserve: modifiable lifestyle activities or behaviors such as exercise, sleep, nutrition, so on and so forth. Social contact, which I think we all appreciate as of late, is so important for our mental and cognitive health. Cognitive stimulation, level of education. There's a lot of different things that can contribute to cognitive reserve, as you know, things like novel or stimulating experiences. And I think the idea is, how can we take exercise, which is usually looked at as just one element of cognitive reserve, and make it more novel, make it more cognitively demanding, make it more social, make it something that provides a positive affect and mood. And so we're not so focused on the scale or the biomechanics, but we're focused on delivering this dosage of higher cognitive reserve for our clients and patients. And this concept of neuroplasticity, which is something that you've heard of, is available to us well into late adulthood. But I think the key thing is the amount of effort required to elicit that neuroplastic change is usually greater with age. So while we're very young, we're very sensitive to external experiences. Our brain's changing so rapidly. It's plastic, it's moldable to these experiences. And that is true as we age, but the effort required to elicit that change is greater. And I think that's true for a majority of biological processes as well. But it's interesting to know that typically as we age, we do less cognitively and less physically. So when we retire, for instance, how do we replace the cognitive demands that we had from our job? As our children leave the nest, right? How do we, and I don't have children, but I'm just speaking theoretically here, how do we replace the cognitive demands from that? And so we typically are lacking these cognitive demands, and exercise is such a great way to supplement that cognitive stimulation that we used to have, for instance. And so the amount of cognitive and physical effort required is greater, and that's why it's also important to not adhere to these stereotypes that older adults should not be eliciting physical or cognitive effort. This is what I was talking about with cognitive reserve. Here are all the different factors, those modifiable health factors: education, social support, positive affect, stimulating and novel experiences, and cognitive training. And the idea is if we can incorporate as many of these into our exercise interventions as possible, theoretically that would increase the dose response on cognitive reserve, ideally to be greater. Now, what are the two types of neuroplasticity? So there's structural neuroplasticity and there's functional neuroplasticity. Structural neuroplasticity is when we actually physically change something in our brains. This is further demonstrated by a process called neurogenesis, a process by which new neurons grow in certain regions of the brain, such as the hippocampus, an area of the brain responsible for learning and memory. Functional neuroplasticity includes the connections that are modifiable between these neurons. New skills and experiences can facilitate this, and repetition and practice can strengthen this. However, if we're not utilizing those connections, they can weaken. Now, how long does it take for these things to occur? Well, synaptic modification, such as, these processes facilitate motor learning and people accommodating their changes in power and gait, and all these things can happen very quickly. And so synaptic modification can happen within milliseconds. Branching of synapses and dendrites can happen within several hours. New brain cells at a significant level take several days, but changes in neuronal networks can take several weeks and months. However, what we're probably after is higher level brain changes and slowing the overall decline of brain volume or even increasing brain volume. That can take several months and years. So brain health can be a short-term goal when we look at subjective cognition and mood, but we also want to make it long-term goal. We want those adaptations to stick, and we want increases in brain volume, or at least slowing the decline of behavioral and volumetric outcomes. Now, we know that when we exercise, we can increase brain volume and increase the prevalence of neurogenesis in certain regions of the brain. And we also know from research that approximately 80% of the brain's gray matter, which is a type of brain tissue that's sort of on the cortical surface of the brain, about 2 inches thick, for instance, and about 80% of the brain's gray matter is modifiable by physical activity and exercise. So in other words, exercise professionals and movement professionals have the power to influence the brain strongly, and we should consider that. Now, we're going to be talking about some different regions of the brain. Just to give you an idea, the regions we'll be talking about are the prefrontal cortex, right in front of the head there, typically responsible for things like executive functioning, motor planning, among other things. The parietal lobe, sort of, if you put your hand on top in the middle and sort of move it back a little bit, your parietal lobes integrate sensory information as well as other things. If you put your hands over your ears, the temporal lobes are right underneath that. They house the hippocampus, an area of the brain responsible for learning and memory. If you put your hand on the back of your head, you'll be right on top of your occipital lobes, which is responsible for vision and processing visual information. And then below that, sort of at the bottom curvature of your neck, right behind the spinal column, you're going to find the cerebellum, which is responsible for all sorts of things, but primarily motor learning, control, coordination, task switching, things of that regard. There's also this concept of functional brain networks. So it's not just regions of the brain, but also how these regions of the brain talk to each other or crosstalk in a functional activity pattern, meaning they're exchanging electrical activity in a specific pattern. So we're not going to be talking too much about these, but there's the default mode network, which is activated when not performing a task, usually in daydreaming, mind wandering, and thinking about others. The salience network is switching between the default mode network and the central executive network. And the central executive network is engaging your conscious brain in a task to think and maintain attention. Now, I think where we'd like to go as a movement profession is there's a lot of activities that are in the default mode network. In other words, if you can zone out and watch TV or just kind of zone out while you're exercising, that doesn't require a lot of effortful focus. Now, that doesn't mean that's bad, but for the purpose of this presentation, we're going to talk about strategies from going from default mode to more central executive network. Things that engage our brain where we're focused on a task, and we're going to describe why we might want to do that. Okay, conscious of our time here, I just want to make sure are there any questions so far? If not, no worries, we'll continue, but if so, please do not hesitate to enter any questions into the chat or Q&A function. Let's move on with exercise in the brain. Not seeing any questions here. All right, so what happens with exercise in the brain? So there's various things that happen at 3 different levels. The behavioral level is what, let me get my annotation tools out here. So the behavioral level is up top here. We're looking to see how exercise can impact behavior. That includes cognition, mental functions such as attention, memory, processing speed, but also mood, how we feel. How are we feeling after exercise, both in the short term and the long term? I think we'd all agree that we feel sharper and better most of the time after exercise, and that's a behavioral level event. But there's also changes at the micro level, and that includes the expression of molecules, proteins, and hormones such as BDNF or brain-derived neurotrophic factor, also vascular endothelial growth factor or VEGF, insulin-like growth factor, IGF-1, irisin. These are all growth factors that you may hear about that cross the blood-brain barrier, are expressed as a result of physical activity and exercise, and can facilitate neurogenesis, synaptogenesis, and angiogenesis. In other words, the creation of new brain cells, new connections between them, and new vascular pathways that can feed them. And also at the micro level, we have neuronal changes in neurons and the connections between them. And at the macro level represents changes in brain structure and or higher level changes in these functional brain networks. That's what we're really after in the long term, just as if you may be after a hypertrophy goal, an increase in cross-sectional muscle area. We know that on the way to the goal, we're gonna see physiological adaptations that are beneficial, that are desirable, but really we're chasing that hypertrophy goal in the muscle tissue. Well, for the brain, we're also chasing this volumetric change in the brain, or at least a prevention of losing some of that volume with exercise and physical activity. But we're also looking for healthy levels of brain activity in which individuals may experience as they age, some normal, some abnormal, changes in brain activity, even though the structure may not change that much. So for instance, if I threw you a ball, an older adult going through normal, healthy cognitive aging compared to a 20-year-old might need to recruit more prefrontal or more occipital brain activity to catch that ball. And more activity sounds better, but we actually want less activity, which would be more efficient as expressed by that younger individual. So more efficient brain activity across brain networks is also a desirable goal for us. So these are different ways in which exercise can affect the brain, the behavioral, the micro, and the macro. Now, what are the recommendations for brain health as it relates to exercise? Well, you've probably all heard this from the Physical Activity Guidelines for Americans, 2nd edition, also perpetuated by ACSM, that for substantial health benefits, adults should do at least 150 minutes to 300 minutes a week of moderate to vigorous intensity aerobic exercise or equivalent. I'm sure you've all heard that again and again and again. Well, this 2nd edition recently included cognitive benefits as a result of this prescription. That is a good thing. I think we need to recognize, as basic as this may seem, that most individuals, sometimes including ourselves, are not reaching this. So this is a great goal to have, is to get towards this and maintain that across the lifespan, in which most people are not, most older adults are not, and we need to get people to get there on their own through exercise programs that are either facilitated or given or prescribed. In addition, there's additional benefits for strength training 2 to 3 times a week, which we know is a really important component. And certainly strength training can increase cardiovascular fitness levels if applied in a specific manner. And we also want to include neuromotor training. Now, neuromotor training is not something you typically hear about. Neuromotor training can include balance, proprioception exercises, coordination exercises, and also skill-based modalities like dance, sports, and martial arts. And I think it's something that is usually missing from our rehabilitation and fitness programs, or if we incorporate it, we may not have a specific rationale as to why to do that. A lot of the times we may integrate those things for balance, proprioception, and dynamic balance and things of that regard, and that makes a lot of sense. But we're going to be focusing on the neuromotor category as it relates to dual tasking and exercises with a cognitive load. Now, if I just did aerobic exercise, for instance, is that enough to slow cognitive decline? Well, research shows that a multi-domain exercise program is actually likely to slow cognitive decline more than a single modality or shorter exercise program. In addition, a systematic review has been conducted by Dr. Joyce Gomez-Osman and her team, showing that in a review of over 98 randomized controlled trials of about 12,000 older adults with and without cognitive impairments, 52 hours of exercise led to improvements in executive functioning and processing speed in older adults, regardless of modality. So as long as we can get people to adhere to exercise long enough to hit that 52 hours, that's going to significantly improve executive functioning and processing speed. Now you may be asking, well, across what period of time? 3, 6, 12 months? And the research isn't that specific on that. But if we're gonna exercise at a higher frequency and duration, we're gonna hit that sooner, say in 3 months, than someone who's exercising at a moderate duration and frequency. Maybe we'll hit that in 6 months. And if an individual is exercising at a lower frequency for a much lower duration, maybe it would take 12 months to accumulate those 52 hours. But this is very interesting research that's been done on exercise prescription and cognition. Now, what's wrong with basic exercise, such as aerobic exercise? Well, nothing, but some researchers are saying that we may have an opportunity to increase cognitive outcomes as a result of exercise by incorporating certain elements. And that might include going simply beyond just moving to moving with thought. In other words, Dr. Adele Diamond may have been saying going with cognitive load to a degree. So most exercises require little thought. Cardio machines, basic weight machines, brisk walking, these are helpful and have their own unique cognitive demands, but perhaps not challenging cognitively enough. Now, cognitively engaging exercise appears to have a stronger effect than non-cognitively engaging exercise, according to some research. And it's recommended that we want exercises that train and challenge diverse executive functions, such as impulse control, updating our attention, being flexible to different types of circumstances, such as those found in dance, sports, and martial arts. What can we learn from these? And also focusing on the qualitative exercises that bring joy, pride, and confidence, giving people a sense of accomplishment, but giving them a sense of challenge. And I think this is important for older adults that may feel that they can no longer participate in sporting activities, for instance, because they've dismissed themselves, maybe due to stereotypes, maybe due to negative evidence that they have, or negative age beliefs or assumptions they have, that they cannot be athletes. And this is excluding masters athletes who clearly don't believe that. But I think bringing in this concept of challenge, cognitive and physical challenge, things that are found in dance, sports, and martial arts, and bringing that to the active aging community is extremely valuable. And I think dual tasking, as we'll present, provides an opportunity in which to do that. So there's also 2 types of skills that I think we should talk about. The first thing we'll talk about is open skills. And open skills include activities that are involve the environment constantly changing. Movements have to be continually adapted, and they're predominantly externally paced. This is found in dance, sports, and martial arts. And then there's closed skills, things that are stable and predictable. Movements have a clear beginning and end, and a performer knows what to do and when. This is found in exercise machines, where it's very controlled, 3 sets of 10, 3, 2, 1, concentric, eccentric, isometric, so on and so forth. And so we want to know what types of activities most of our clients or patients are participating in. I think most of us would agree that if we're looking at the rehab and fitness industry as a whole, we're looking at these closed linear skills. Now, are those bad for brain health? No. In fact, a majority of the past decade of research on exercise in the brain has focused on closed skills because they're measurable, they're repeatable, they're exactly as they say, they're stable and predictable. But open skills also seem to have this unique opportunity for enhancing cognition. In fact, there's some systematic reviews showing that open skills can enhance cognition in some cases better than closed skills. But it doesn't mean that closed skills are bad. We still need that aerobic training. We still need that resistance training that may be more linear and predictable. And what we're looking to do is not do open or closed. We're looking to incorporate more of what we're not doing. So if we can all agree that a majority of the exercise that people are participating in is closed skill, maybe we need something that's also more open skill to accommodate that. And this is a spectrum. This is not a light switch. So we want to occupy this spectrum as much as possible. So it's good to have stuff in the middle. For example, Olympic weightlifting involves things that have to be continually adapted to, maybe externally paced, but we will also want some sort of predictability. 3 sets of 8, for instance, clear beginning, clear end. Now, that doesn't mean they're better than machines. It doesn't mean they're worse than tennis, but we want a variety of closed and open skills and everything in between. Now, when it comes to motor learning, let me just go to this slide here. We typically look at teaching people new skills, mostly in the context of sports, dance, and martial arts. But in the context of rehab and fitness, we do consider motor learning a part of what we're doing, usually in response to teaching novel skills or maybe looking at neurorehabilitation. But in the context of fitness, while we will show people new exercises, we're not thinking of motor learning typically. We're not usually thinking of the cognitive benefits of teaching novel skills, as which we talked about can contribute to cognitive reserve. So if we're looking to teach novel skills and stimulating activities, we want to consider the cognitive challenges that can come from skill learning. And so if we look at this top stage, this cognitive stage, we'll see that cognitive demands, this is why it's called the cognitive stage, are highest at that stage. So when we introduce a new skill, that has a very high cognitive demand. And sometimes that can be frustrating, a little awkward, but as we learn it, we get more towards associative. And then as we practice and practice in that associative phase, we get towards more of the autonomous phase, which is more automatic processing. Now, the issue that I have with things like routines or movements that have been really well learned, if we're going to consider cognitive load, is that they have very low cognitive loads. Now, people often avoid novel skills because they're awkward, because they're frustrating, because they're cognitively demanding. But I would say in this case, novelty can win. Now, it doesn't mean that new skills are always better, but I think we should consider the novelty of skill and the skill demands and the cognitive demands of that skill an acute variable beyond just sets and reps. So in other words, going from beyond rep counters to skill teachers. I think that's a really important thing to consider if we are to deliver more cognitive load to our exercise programs. Now let's talk about the potential benefit of combining cognitive and physical load. So what's happening with no training, no cognitive and no physical training, is that we are losing neurons. With physical exercise, we gain neurons, but we may not keep them all. With mental training, it stimulates neurons and therefore increases the chance that we can hang on to those. But with mental and physical training, one of the theories is that we generate neurons from exercise, that neurogenesis process, and perhaps we further integrate and help them survive through the simultaneous or sequential incorporation of mental training. So it's almost like getting a bigger return on your investment, and that's what we're looking to achieve. So this is a graphic that's quite busy, and the reason I created this graphic is to summarize what different types of stimuli and types of physical activities and exercise might be able to do for different brain regions. And some of the evidence that inspired this is weaker than others, some is stronger than others. But I like this graphic because it helps us appreciate the value of variability, of input variability, as well as a variety of cognitive demands in exercise and physical activities that may contribute to what I loosely might call a whole brain exercise program. So for the frontal lobe, there's research showing that cognitively demanding activities, in other words, open skill activities, which we've defined, as well as resistance training and mind-body training, can lead to increased gray matter, improved executive functions, and more efficient brain activity. Cardiovascular exercise can increase the volume of the temporal lobes, as can closed skills activities and just general physical activity. So those who walk more blocks or more steps, it's been shown to positively affect this area. That leads to improved learning and memory, neurogenesis, and hippocampal volumes. And once again, the hippocampus is an area of the brain responsible for learning and memory, in which its shrinkage or change in function is usually attributed to age-related memory loss. The parietal lobes, those are likely to be stimulated with object-based or sensory-rich activities, and that can increase white matter and volume. It can improve sensory network activity and improve task switching abilities. There's also some interesting research showing that masters athletes, in comparison to sedentary older adults, have greater volume and function of the occipital lobe. And so there's more research recommending that these visuospatial and object demands, visual attention demands, and these motor control demands may contribute to the structure and function of the occipital lobe. And then we have the cerebellum, as well as the basal ganglia, which is deeper brain structure implicated in Parkinson's disease, for instance, that seems to be responsive to coordinative and motor exercises, that neuromotor category, in which cerebellar volume and function has increased, as has coordination and attention, as well as in some rat studies showing higher nerve cell and blood vessel volume in this region as a result of coordinative activities. So there's some early research showing that for the cerebellum and basal ganglia, these posterior, deeper regions of the brain, motor fitness seems to affect that area, but cardiovascular fitness does not, whereas cardiovascular fitness might be more temporal. Now, of course, this isn't exclusive. There's research showing that those with higher levels of cardiovascular fitness also have improved frontal lobe function and structure. And I don't want to say that one type of activity only targets one area. But this is an interesting way to look at exercise and physical activity, as it can give us an appreciation for the value of variability, but not just variability for the sake of variability, but structured and targeted variability. And this is why it's also important to integrate with medical professionals, as some of your clients or patients may have volumetric MRIs that can help us find, hey, this individual has decreased basal ganglion volume. They're not exhibiting any Parkinson's symptoms, but maybe they could benefit from motor fitness, as the only type of exercise they're participating in is aerobic exercise. Or maybe this individual is exhibiting executive dysfunctions, issues with impulse control. Maybe they're at high risk for falls. Maybe we want to incorporate resistance training, as that's been shown to incorporate or improve executive functions to a degree. So this type of thinking is what we are going to be provided the opportunity to consider in the future, or now, if you so choose to learn it. That's a busy slide, so thanks for staying with that one. So any questions so far? We're going to move on to our practical applications now. We're about halfway through this talk. If there's anyone who would like to ask a question, please enter any of your questions into the chat or Q&A. I'm going to take a sip of water because I talk very quickly and usually without stopping. All right. I hope I've put none of you asleep yet. So, all right, let's continue. So dual tasking, what is it? Why do we care? Well, dual tasking is defined as the ability to train individuals to be able to perform two tasks simultaneously, one primary and one secondary. And they can be performed independently. So I can text independently and I can walk independently. In other words, I can text without walking and I can walk without texting. They can also be measured separately, either in biomechanics, gait speed, typing speed. There's a lot of ways to measure that, just as an example, and they have distinct goals. One, I'm going to the coffee shop over here by walking. The other, I'm talking to my friend and maintaining that relationship by texting. And so when performed together, this is called dual task, and there's different types of dual tasks. And we actually want to be able to improve dual task ability for a variety of reasons that we'll talk about. As dual task ability seems to decline with age, it also is declined with certain neurodegenerative diseases, but in different ways. And also, we talked about neuroplasticity, and it's well available to us late into adulthood, but we need more effort. And remember that we may be dual and multitasking as we are having these cognitive demands in education or our occupation, or as we have kids or pets, and that tends to dissipate in its frequency, intensity, or volume as we age. And so how can we replace that? And research has also correlated dual task ability with cognition. And interestingly enough, dual task ability has been correlated with gait and balance performance, as have cognitive abilities. So interestingly enough, a lot of people fall. Let's just talk about falls, for instance, because we're not just interested in cognition, but also fall prevention. Dual tasking, multitasking, and falls and gait. So when do people actually fall? Do people typically fall because they're focused on their balance and gait, or do they fall because they're distracted? So for example, I fell when I was carrying some groceries. I tripped or I caught my foot on the sidewalk when I was having a conversation walking with my friend. I wasn't paying attention and therefore I fell. Oh, I was looking at my phone. Next thing I knew, I was on the ground. They had no conscious awareness of why or how they fell. And all these things can be related to dual tasking failures. These people failed to dual task, multitask, or task switch, and therefore these falls occurred. And this is often when falls happen. Now, dual task interference does increase with aging. You may observe this in your clients, patients, or even yourselves. I know that after a bad night of sleep, my dual task interference is greater. So this is elicited or demonstrated in stopping to walk when talking, or vice versa. So if people slow down or stop walking in order to talk, or their talking slows down as they're walking, this is an example of dual task interference. Or word finding abilities are more challenging while you're walking. You're struggling to have a fluent conversation, or as fluent of a conversation as compared to when you might sit down. Eating and talking, short-term recall of a password while setting up an account, for instance. These are all real-world examples of how dual task interference can be prevalent in the aging process. Now, there's different types of dual tasking. You may be thinking, well, what's the difference between these types of examples Ryan's giving here? Well, there's cognitive motor, which is essentially a cognitive task and a motor task. Let's say trying to remember something as you're walking or having a conversation while you're walking. Then there's motor dual tasking. And an example of motor dual tasking might be carrying a glass of water or trying to get something out of your purse or pocket while you walk. And then there's sensory motor dual tasking, in which your head turns, your eyes are scanning the environment before crossing the street as you're walking, for instance. And so there's cognitive motor, motor, and sensory motor. And there's ways to train these individual functions. Now, primarily for this presentation, we're going to be focusing on cognitive motor. How do we address those cognitive functions in a simultaneous motor task or with a simultaneous motor task? The motor, and sensory motor are extremely important for fall prevention, activities of daily living, things of that regard. But primarily, we're going to be focusing on the cognitive motor. Now, why might we care about these cognitive motor functions or sensory motor functions? Well, research is starting to suggest this may be how we evolved, where we evolved with visual tracking and cognitive processes simultaneously combined with some sort of physical processes. So in this more of evolutionary example conducted or presented by Dr. David Reichlin and his team, what we're seeing here is some sort of prey. And we know that prey rapidly changes directions, usually without notice. And that requires our executive functions, things like problem solving, cognitive flexibility, decision-making, planning, so on and so forth. But it also requires our sensory and attention systems. We have to pay attention. We have to manage our vestibular responses and our postural control responses. We also have to use our spatial memory and navigation systems to navigate an environment. Then we also have to use motor control and learning, and we have to go from slower speeds to faster speeds. So if we put this in a gym environment, instead of the prey, maybe it's the trainer or the therapist, yourselves for instance, or the stimuli that is being provided to the individual, either through the therapist or the trainer, or through a technology like an app or a machine, for instance. And the individual would have to use their sensory systems to respond to those more open skill or unpredictable cognitive demands. And they may have to use their spatial memory and navigation systems for, oh, I'm supposed to step this direction when I see this, I'm supposed to step this direction when I see that, and oh, I have to use my motor learning and control systems to manage this new tool, whether it's a kettlebell or a dumbbell or a viper or a tennis ball, in response to those functions. And then I have to go from a slower speed learning the task to a faster speed, whether it's marching in place quickly or faster gait under those conditions. So you see how we occupied each of these potentially evolutionary functions in the clinic or in the gym. So I just wanted to give some theoretical examples for that. Now, another rationale why we consider incorporating cognitive load is because it's completely integrated with the other outcomes that we're after, and it's integrated with how people age. So with gait and motor impairments, that is usually correlated to high dual task costs or that increase in dual task interference. In addition, it's bidirectionally correlated with cognitive impairments such as memory or executive impairments, and that is correlated with dementia syndromes and increased falls and fractures. And some of the median variables can be perhaps the prevalence of mild cognitive impairment, Parkinson's disease, vascular cognitive impairment, or slower gait velocity, for instance. So this is just showing you how the spectrum of cognitive and mobility outcomes is correlated in the role of neurodegeneration and aging. So all of these things are integrated. Therefore, we need to incorporate cognitive load into our falls prevention programs, and cognitive rehabilitation clinicians, such as neuropsychologists, speech language pathologists, occupational therapists, should incorporate movement as well in their cognitive rehab interventions for these reasons. Now, while it's a little outside the scope of fitness professionals, maybe more of interest for rehab professionals, but I think just interesting for everybody, is that dual task ability and the response in which individuals respond to dual task paradigms might be able to help detect one neurodegenerative condition versus another. In other words, an individual with prodromal or early Alzheimer's or Parkinson's disease might respond differently. So a person with earlier prodromal Alzheimer's disease or an individual with Alzheimer's disease might respond differently than an individual with Parkinson's disease. And that could be due to the attentional control of gait versus the automaticity of gait. It's a little bit more of a complex topic, but I think it's interesting if we were able to measure dual task ability and train it, how would it look in different conditions and when we're considering preventing some of these neurodegenerative conditions. And also different parts of the brain and different cognitive functions might be linked to different aspects of gait and balance. For example, how interesting would it be to know that memory and the temporal lobe functions, for instance, are related to the pace and rhythm of gait? What if we were to incorporate memory tasks while challenging someone to maintain a pace and rhythm of gait, for instance? So this is also a bit of a more complex topic, but as we get more research, perhaps we can be more precise with our cognitive motor interventions. Now, let's talk about automaticity versus cognitive load. I think it's important to discuss. So when our processes are automatic, let's say for individuals unaffected by neurodegeneration or abnormal neurodegeneration, i.e. those without Parkinson's disease or abnormal neurodegenerative processes, automatic processes are primarily stored in the M1, the primary motor cortex, the spinal cord, and the cerebellum. That's a direct locomotor pathway. But as we start to incorporate more cognitive load, we're taking those functions that are posterior to the brain and more automatic and moving them forward to the prefrontal cortex, the supplementary motor area, and the basal ganglia. And so this is especially helpful for individuals with Parkinson's disease who've lost the automaticity of gait, as great lecturers out there like Dr. Mike Suter will teach, that actually bringing that back to the front of the brain, make it more cognitively demanding, can help with restoring automaticity. For us, we're also interested in how we can engage that prefrontal cortex in relevance to certain movements and tasks that have just been automated. So we've also talked about the prefrontal cortex, and an example of how it can be related to falls, for instance, is that it can help control attention, dual tasking, and impulse control. And divided attention and other executive functions do decline with age. And so when falls happen, are we focused or distracted? And I would argue that we need to train distractible ability, dual task ability, divided attention, task switching in our clients and patients if we were to want them to be successful in the real world over the long term. So we've sold this enough to you. We've talked a lot about the science. Let's get to see how we can actually assess dual task ability. So let's watch a quick video on a study that's actually incorporating both dual task assessment and training in a combined cognitive physical intervention. So I think this is just a helpful video because it helps us look at what sort of studies are being done and how this might be applied.
Which comes first? Does exercise lead to better brain health, or is it the other way around? And can improving a senior's mental capacity by playing brain games help increase his or her mobility? Ursula Perry reports those answers come from a study that's the first of its kind.
Okay, begin. 73-year-old Marlene Ray knows all too well that aging is tough on the body and the mind.
My sister-in-law suffers with dementia, so I want to know what I need to do to help anybody else I can while my mind is still sharp.
Ray is one of more than 400 seniors being recruited by researchers at Albert Einstein College of Medicine for CREM, the Cognitive Remediation to Improve Mobility study.
And it's based on the idea that to walk in the real world, you need to engage your brain.
3 days a week for 45 minutes, half of the seniors in the study play computerized brain games that target the areas of the brain important to mobility and executive function. The prefrontal cortex, the basal ganglia, and the connections in between.
A, C, E, G.
Participants then perform timed walking and cognition tests, seeing how long it takes to walk a runway while reciting alternate.
So you saw that she was executing a task in which she was alternating letters of the alphabet. And the reason that's important to remember is because she's actually doing a dual task assessment right now, in which she is doing that as she walks. But first she performs that cognitive task separately, and then the walking task, and then together. So remember, the definition of dual tasks is they can be performed and measured independently, and they should be if we were to calculate dual task cost.
Alternate letters of the alphabet are finding a way out of a floor maze while keeping one foot on a yellow guideline. Marlene, who performs with her church, says since beginning the program, she's seen a big improvement in movement and memory.
I did a show in December with my choir. We did and I had to remember 12 songs.
We hope to see at the end of the trial that we would have reduced the amount of effort the brain has to do while walking. In other words, making the brain more efficient.
As part of this study, scientists are using special scanners to measure the amount of brain activity. A small study has already been completed showing the participants did improve their ability to walk. Now a larger randomized study is underway, and it should run through the year 2020. Ursula Perry, KSAT 12 News.
All right, so you also probably saw that they were doing some cognitive training seated with a computer. Now that's just to show you they were looking at more sequential tasks as well. In other words, doing physical activity and then doing cognitive training separately. But they also use dual task assessment. Now that's to show you that cognition and mobility are interconnected. But what we're talking about is the simultaneous execution of those rather than the sequential. Both can be beneficial. There's some research showing that the simultaneous performance of a cognitive and physical task may be better for some cognitive outcomes, although more research is needed, like everything else. Now, there's another way of assessing dual tasking, which is another example might be a dual tasking questionnaire. Now, I'm not suggesting that you use this, but you could. It's a way of assessing subjective dual task ability. And there's a range of these from agreeing, from never, scored at 0, very often scored at 4, and some options in between. Are you paying attention to more than one thing at a time? Do you need to stop an activity to talk? Do you spill a drink when carrying it? All these questions about real world dual task performance. And they're all scored and then averaged. And then I believe there are good normative values for this. That's just called the dual tasking questionnaire. So you may not even need to perform a physical dual task assessment to gauge an individual as to whether they notice these changes in their life. Or maybe they just weren't aware of these challenges, and by discussing it in your rehab or fitness environment, it brings it to their awareness. So like, oh, I didn't know that was a problem. And maybe it opens the conversation to, oh, I've also been noticing other types of cognitive abilities decline. Is that something we can work on? And also maybe lead to the referral to medical providers that can lead to early detection or diagnosis of cognitive disability, for instance, and catching it before it's later down the line. And so that conversation, that awareness can bring about a lot of benefit, whether you're directing it or addressing it directly, or you're bringing awareness, or it leads to a referral to an allied health professional. And so there's different types of dual task assessments. We'll talk about some of them. Really, the one we're going to focus on is the TUG cognitive. The TUG standing for Timed Up and Go. I'm assuming you know about it. If not, here's a video courtesy of Dr. Chris Thompson from Mobility Matters, showing what a timed up and go would look like.
This is the walk test. This assessment is our assessment for gait enhancement and dynamic balance. I have Alex here helping me with the walk test. What we're going to have him do is see how quickly he can walk around the cone, come back and sit down. Here's what the test is going to look like. Alex is starting the test with his feet flat on the floor, his hands on his lap. When I say go, he's going to stand up, walk as fast as he's comfortable around the cone, come back and sit down. I'm going to time him on the stopwatch to the closest 1/100th of a second. That's it. Alex, let's do this test. I will give you a ready, set, go command. Ready, set, go. Around the cone and come back and have a seat. 8.92 seconds. Very good.
All right, so that's how you conduct the timed up and go, just in case you weren't familiar. With that said, let's see how it's timed up and go cognitive is conducted. So you must do the timed up and go as a normal condition and then do a dual task version of it in order to calculate the dual task costs, as well as to see the effect on gait speed and things of that regard.
What we're going to do now is we're going to superimpose a cognitive task on the TUG. So we're going to ask Bruce to do a cognitive task while he's running this same test. There are a variety of different ways to do this. We're going to start with a math task, and we're going to see how Bruce does with a math task. In the clinic, when I'm really trying to get good data on this, sometimes if I have somebody with me, a PT tech or an aide, I'll have them jot down the answers that somebody's giving. So I'm going to have Bruce do a serial subtraction. So we'll do that here. I'm going to give you a starting point, Bruce, and then I want you to do some math as you're walking. From the starting point I give you, I want you to subtract 3, and I want you to continue to subtract 3 as you're going, okay? So you're going to do this test, but I want you to do this cognitive task while you're doing the walking task, okay? Good?
Instructions are important.
3 from where?
I'm going to tell you where to start if you tell me you're ready. Are you ready?
Yeah.
Okay, I'm going to have you do that subtraction, and I want you to start at 99. Go.
99, 96, 93, 90, 97, 94, 81, 79. That was terrible.
Okay, so you heard some errors in his math. So there was some decompensation from the cognitive task as he went. His timed score was at 8.92 seconds that time. And so we really saw when there was the divided attention or the demand of both the motor task and the cognitive task, we had some decompensation in the cognitive task. You heard him go from the 90s and then stay in the 90s, I think, when he intended to get into the 80s. And he had a little bit of slowing of his gait as he was, as we compare this to his previous scores.
Okay, so we saw that a cognitive task was given. Typically, you want to give that cognitive task before the walking independently. Now, we're not going to talk about how that would be distinctly measured per se, but it's important to know, can they actually count backwards by 7s? And you also can calculate if they're walking slow down, which we're really just looking for seconds, how long the timed up and go took. So for example, if the first one took 7 seconds, but then we added the serial 7 subtraction and it took 12 seconds, that tells us that's a pretty significant dual task cost. And so research has been done correlating these different cognitive tasks superimposed onto functional outcomes across individuals of different ages. And so the reason we pick 7 is because we find that it takes individuals longer. It's a little bit more sensitive and easier to parse out for age, although if they can't really do 7s or they're really just not psychologically into that, we can give them 3s, and that's still gonna, as shown here, it's gonna give us a more sensitive result. That is subtracting by 3s instead of 7s. That is from a random number so that there's no rehearsal effect. We will talk about the Foursquare step test and adding the very same cognitive task layered on top of that as well. We'll also talk about some dual task calculation, but ultimately we're seeing if it takes them longer to do. Now the cutoff scores for fall prevention, according to the Shirley Ryan Ability Lab and rehab measures, is the cutoff score for the timed up and go alone, anything greater than 13.5 seconds, that individual's at a high fall risk. For cognitive, if it's more than 15 seconds, they're at a high fall risk. So that's looking at it from the fall risk perspective rather than the cognitive decline perspective. We can't take a timed up and go cognitive and say, you have mild cognitive impairment, you have Alzheimer's. Although there is research correlating dual task performance with the timed up and go cognitive to cognitive decline, but that's outside our scope of practice. It's just an observation, it's just an additional measure. We're not using it to diagnose people. Then there's a tug manual where instead of the subtraction task, we have an individual carrying a cup of water that's almost full. Traditionally, it's carrying like a cafeteria tray with that full cup of water and doing the same task. Anything greater than a 14.5 second time, it puts them at a higher fall risk. And then there's the tug triple where you're doing the water carrying task with the subtraction task. That's quite a lot. I don't know the cutoff score for that one, but that would be, the manual would be motor dual task, and then the tug cognitive would be a cognitive motor dual task, and then doing the tug triple would be a cognitive motor dual task, or triple task, I suppose. And so these are helpful to integrate, even if you're not so mathematically specific with them and you're just getting a qualitative observation, that is also valuable in bringing awareness to the client or patient that, hey, this is something we might want to work on. Now for the Foursquare step test, we'd start in the upper left-hand corner with 1. We go 1, 2, 3, 4, 1, full clockwise rotation, and then immediately go backwards to 1, 4, 3, 2, 1, go counterclockwise. that is one round. And so you're timing how long it takes for them to go clockwise and counterclockwise. Then we can add the cognitive and or the manual task on top of that. As we've talked about, that would be the serial 7 subtraction task or the serial 3 subtraction task if the serial 7 could not be conducted, and or the every other letter of the alphabet task starting with a random letter. While I don't necessarily recommend that you do this because normative values are not available, it's an interesting test to conduct. Dr. Mike Studer has also created a more practical version of this test where we're taking a trail making task, which is usually conducted in neuropsychology to measure processing speed and task switching components of executive functions. There's a walking variation. And so you would place different dots on the ground within a pre-measured and defined area, going from 1 to 14, for instance. You go from 1 to 2 to 3 to 4, and you could time individuals to see how long it took them. And then the task switching paradigm would be trail making part B, in which we're going from 1A to B, 3C, so on and so forth. And so this is interesting to look at for processing speed as it relates to gait simultaneously, as well as task switching as it relates to gait. It also can be done potentially as an exercise if the properties of the assessment are not exactly replicated. And you can substitute as an exercise the numbers, substitute the numbers and letters, for instance, such as switching between numbers and days or months of the year, for instance. So there's all sorts of ways to incorporate this into assessment. To look at more visuospatial navigation, there's something called the Corsi block test. And this is like choreography, for instance, but adding more visuospatial demands on top of it consecutively. So for example, if we look at the numbered blocks on the left-hand side, and I've done this with just agility ladder squares sold by Skills. The Pro ladder, they have these little squares, and I'll put about 8 or 9 of them on the ground. Maybe I'll put a numbered dot in the middle, and I'll go 1, 5, and then they step on 1 and 5. Sometimes I'll step in the order that I want them to repeat, or I'll say it, or I'll shine a little laser pointer in there to show them the order in which they must step into those squares. And I'll go, if they did 1 and 5, I might go 3, 8, 4. So I went from 2 to 3 and then 4, and we're seeing where they max out. Can they get anywhere from 5 to 7 squares in a row, where a longer version would be 7, 5, 8, 3, 2, and they're stepping on it in that order. This is a little bit harder to measure, but it's interesting when we look at it, and it sounds a lot like, well, how might we train that, for instance? It sounds a lot like choreography to a degree, a more complex series of steps. But this is based off the Corsi block test, which is a measure of visuospatial working memory. And so it's just to show you that these neuropsychological tasks with more research could be adapted in a movement in primarily a clinical setting. I think the role of these more clinically inspired tests may not suit fitness that well, but I think definitely rehabilitation, these would be very well suited and appropriate. Now, how might we calculate dual task cost? Well, let's say we did the timed up and go cognitive. We'd take the dual task cost in seconds, and we compare it to the timed up and go single task condition in seconds. Let's say 12 minus 7 divided by 7 times 100, and you would get a negative percentage that is correlated with dual task cost. We, of course, don't have time to give an example, but that would be one way you calculate dual task cost if you wanted to report that on your notes, for instance, especially if you're a rehab professional. Now let's talk about dual task training. So for the purpose of this webinar, we're going to focus on 4 types of cognitive domains: attention, which includes attending visually or auditorily to stimulus; processing speed, which focuses on less complex bottom-up processing or reactive or reaction time, to put it more simply, and it's present in all tasks but measured by time. And then we have executive functioning, more complex top-down tasks like impulse control, cognitive flexibility, planning and organization, and then memory, the encoding, storage, and or retrieval of a variety of different types of information. Now there's all sorts of ways to incorporate dual tasking. There's low tech or no tech. There's what I call mid-tech, using apps, for instance, which we'll go over a couple that are on the market. And there's high-tech, using technologies like SmartFit or virtual reality, for instance, that are also on the market. That can be helpful if they are affordable or accessible to you. And when we're looking at emphasizing these different cognitive domains in these cognitive motor tasks, it's helpful not to look at them as if I'm training them or not, but rather as volume knobs. And just like the body, cognition is integrated into real life. And so it's helpful to look at these volume knobs as it relates to how much of this domain is being required during these tasks or this task. And there's also a matrix in which we might load physical and cognitive load from low physical to high physical, low cognitive to high cognitive, both simultaneously or independently. So I could keep a task relatively low physical, let's just say standing with my feet together, that's not very physically demanding, but steadily increase the cognitive task. Or I could have a very hard physical task, let's say alternating jumping lunges for an individual, and I could keep the cognitive task consistent as I increase the demand of the physical. So I'd start with a reverse lunge, back to the middle, reverse lunge, back to the middle, then alternating lunges, and then alternating jump lunges. Or you could increase them simultaneously together. And some people might say, well, how might I gauge physical and cognitive load for some of my clients or patients, especially in a group class setting? Do I put someone with a low capacity with a high capacity? Well, it's possible, but ideally you put them in different difficulty levels. So here's some examples. Low physical and low cognitive load can be in 1, medium level 2, high level 3, for instance, just a suggestion. And as we're doing this, we want to keep elements of gamification in mind, challenge, reward, engagement, some competition, friendly competition is sometimes helpful, having a goal, teaching a skill, having that sense of accomplishment. All of these elements of gamification are helpful. Understanding that we may not have technologies that are actual games, although their presence is proliferating the rehab and fitness market even more so, extra gaming as it's called. And I think we can just learn from that and say, how can we incorporate that into our exercise techniques? And another thing to keep in mind on that note is a challenge of balance and skills, in which we want to maintain this flow state. So if we give someone something that's too hard, they might get frustrated. If we give someone something that's too easy, they might be bored. Also understanding that as we train someone, their skill level will increase, and therefore the challenge needs to increase both physically and or cognitively. So let's start to go into some practical applications. Let's start with a reaction time drill, just using a visual perceptual demand like a tennis ball, incorporating it on top of a physical task. And you'll see how I scale it a little bit to be more cognitively and or physically demanding, as well as elicit response based on the individual's experience of this. What was their perceived cognitive and physical load? So I'll be quiet so my virtual self can start.
Showed you the fast feet movement. That's going to be more of a cardiovascular progression for this exercise. I'm also going to add more of a reaction time demand on this. I'm going to have you place your hands behind your back. I'm still going to call out left or right, and either the left or right hand will come out based on what I call, okay?
Okay.
So let's practice this without the quick feet really quick, okay? So left, right, good. Make sure it goes behind the back again after every repetition. I don't want the other one coming out to say hi, just the one that I call, all right? Right, good. All right, so let's start the quick feet movement. Get a little bit more of a cardiovascular demand. Try to stay in place. Left, good. Hand goes behind your back. Right, left, right, left, right, left, and good. How was that?
That was hard.
That was hard? Scale 1 to 10, how physically demanding was that?
So you heard me ask a question. On a scale of 1 to 10, how physically demanding was that? 10 being the most. And then I asked on a scale of 1 to 10, how cognitively demanding was that? 10 being the most. And based on their response, I can regress or progress that drill, either physically and or cognitively. Now, it doesn't have to be a fast feet movement. It can be a balloon instead of a ball to slow down the time it takes to get there, for instance. And you know, those are examples of modifying the cognitive load and the physical load. I could have my feet together. I could be standing on one leg. There's a variety of ways in which you can modify that drill. So this one simple concept of moving while catching a ball can be progressed or regressed hundreds of different drills, depending on what physical and or cognitive functions you are trying to address. And so that could be throwing this back and forth or keeping a balloon up in the air while walking. You can incorporate gait tasks, vestibular tasks, visual tasks. I could have 2 balls or 2 balloons that are different colors where a left and a right has a different mapping to that, so on and so forth. Now let's see a drill with more of a memory demand. It's not that complex of a memory demand, but it's to show you that sequencing of steps or movements can be very good for challenging things like short-term memory.
Now I'm going to add a bit more of a memory demand for you, okay? I'm going to give you a sequence of steps. It's either going to be left or right, and I'm going to sequence them out, okay? So I'm going to say them, and you're going to have to keep up with them. So for example, if I go left, right, left, show me what that looks like. Good. Nice. So a bit more choreographical demand, if that's a word, right? Okay. Now I'm going to give you longer streams. So if you can do that well, I'm going to give you longer streams of numbers, or sorry, left or directions rather, if that makes sense. Okay. So left, right, right, left. Good. And then what I'm going to do is, before you finish that last repetition, I'm going to start with the next series.
Okay.
So you're really going to have to attend and use your memory.
Right.
Okay? Right, left, left, left. Right, left, right, left.
And you could see over time that I might increase the span of directions. Maybe I add a third and a fourth direction. Maybe I start to add colors, and a left equals a color, or vice versa. And so there's all sorts of ways to progress this. And I'm about to show you a way of making it more cognitively demanding using executive functioning demands, primarily looking at task switching and this equals that sort of paradigm as I layer on these working or short-term memory demands. So let's watch how I do that using my high-tech dots with numbers.
I'm going to switch up the numbers for you. Okay? So now this is 3, this is 2, and this is 1.
So I'm sorry, I'm mapping different movements to different numbers, and you're going to see that as the camera pans out.
And instead of saying the numbers, I'm going to say the colors, and then you're going to have to match those up. So if I say pink, what do you do? Very good. Awesome. If I say green,
no.
That's right. Very good. Okay. And if I say yellow, good. So scale of 1 to 10, how cognitively demanding?
Really hard.
Okay. All right. We're going to move pretty fast. Okay. I think it's difficult, but I think you can do it.
Okay.
Right. Are you ready? I'm going to give you a string of colors here.
Okay.
Yellow, green, yellow, pink.
No, I started wrong.
That's okay. I'm going to give you a different stream of colors. Are you ready?
No. Okay.
Pink, yellow, green. Good.
So you can see she's going through and executing the motions based on the sequence I've presented. So she has to hear the color, look at the answer to get the number to map it back to the movement, a little bit more complex. And so it's great to show how we can modify these, the cognitive and physical load of all these drills. These are just some ideas for you. Now there are some remote virtual training techniques. There's apps, for instance. Sorry, just skipping ahead of time here. Some of my favorite apps include Switched On, which right now is free to download, and you can click this different stimuli, colors, arrows, numbers, have it be presented at different sequences of time. It's a very flexible, great, robust app for delivering visual stimuli and soon to be auditory randomized stimuli. Clock Yourself is also a very valuable app created by Dr. Meg Lowry, who's a physiotherapist, and has this clock-like, she's taken the clock lunge or the clock step and added a very randomized cognitive element to it. You can substitute the numbers with periodic table of elements, months of the year, all sorts of great ideas there. And there's all sorts of ways to deliver that cognitive load over Zoom by screen sharing it, by having clients or patients download it, for instance. Could also be great for homework. There's also, excuse me, because almost sneezed. There's also softwares like NeuroTracker. Excuse me, brain sneeze. Options like NeuroTracker that deliver multiple object tracking over softwares that could be 3D or 2D. And also executed while under a dual task condition like marching in place, balancing, getting on an exercise bike. Also, depending on your scope of practice, there's cognitive assessment tools on the market like Cambridge Brain Sciences. There's Savonics that may be utilized to measure pre and post intervention performance and cognition. There's low tech and high tech tools on the market like enriching your cognitive motor training sessions with speed, agility, and quickness, equipment like skills. There's virtual reality. There's great technologies like SmartFit on the market that incorporate cognitive motor load through these electronic targets. There's mats like Procitos that have different numbers and letters on them for a variety of cognitive demands. So there's all sorts of great products on the market that can help you execute this concept from introductory to advanced. And we have a lot of people that have gone through my course, which I'll talk about now, that have started attracting more people, retaining people because they're incorporating these brain health focused programs, but also making an impact in which it's not just being able to play with their grandkids through functional outcomes, but being able to remember their grandkids' names as a result of your fitness or therapy program. That's very impactful. And so in order to create that impact, we have to have understanding, more neuroscience information, more ideas of how to apply it. That's why I created this brain health trainer course in cooperation with the Functional Aging Institute a year ago. Since then, we've trained 500 professionals, both rehab and fitness professionals, through interactive graphics, neuroscience theory, turnkey programming. And if you want to learn more about that, you can go to www.brainhealthtrainer.com. And for all of you today, we have a special code that gets you 50% off if you use the code all caps BRAIN300 at checkout, all one word, BRAIN300 at checkout. And if you want to contact me, here's my contact information. And I will leave this slide up, and I will put that code at the end so that we can leave it up on my contact in case some of you want to take that down. And I'll start taking questions if there are any. Recognizing our time, it's exactly 1:15 when I'm supposed to be ending, but until someone kicks me out, I will stick around to answer any questions you may have. And thank you so much for being here and attending the Virtual Rehab Summit. I'll stick around once again, just in case there's any questions, which you may chat and enter into the chat or Q&A. Thank you, Pam. Thanks for being here. Also conscious if you need to skip to the next session, I will take no offense. Allow probably about another minute in case anyone has any more questions. Thank you, Pam. Thanks, Nancy. Appreciate the kind words. Thank you, Amy. Much appreciated. Okay, sounds good, Pam. Looking forward to hearing from you.